Welcome you to today's session, and I'd like to welcome the chair of the board of the Canadian Breast Cancer Network, Kathy Mandalea, who is going to do our introductions. Kathy, I'll turn it over to you.
Hi, everyone. Welcome. Good morning or good afternoon, depending on where you are. I'm Kathy Mandalea, the chair of the board for the Canadian Breast Cancer Network, and I'm pleased to welcome you to our first virtual patient education session. The Canadian Breast Cancer Network usually hosts two of these education sessions in person each year. However, given the current pandemic, that is obviously not an option this year. While we cannot meet in person, we are grateful that technology still allows us to connect with people from across Canada and are pleased that you joined us. The Canadian Breast Cancer Network is Canada's only national health charity for breast cancer patients that is directed by breast cancer patients. Each of us on the board of directors has personally experienced a breast cancer diagnosis, and we collectively draw on these experiences and those of our advisory committee members and networks to inform the work that CBCN undertakes. We work to ensure access to the best care for all Canadians with breast cancer, and part of ensuring the best care is making sure that patients are able to better understand their diagnosis, treatment options, and supports to maintain the best quality of life. We know how critical this is, particularly for patients living with metastatic breast cancer. Today, we are pleased to welcome two of Canada's leading physicians, Dr. Gelmon, a medical oncologist from British Columbia Cancer Agency, and Dr. Downar, a palliative care physician from Ottawa Hospital. Our hope is that this session will provide you with the opportunity to hear from these leading healthcare professionals who can share with you the latest advancement in treatments and care for metastatic breast cancer, and who can also answer some of the questions you may have. I would like to express our sincere gratitude for our sponsors who have made this event possible. Our gold level sponsor is Novartis. Our silver level sponsor is Pfizer Oncology. And our bronze level sponsors are AstraZeneca, Eli Lilly, Knight Therapeutics, Merck, and Roche. Thank you for your support. So before we begin, I would like to quickly review some housekeeping items. Each presenter will be answering questions right after their presentation. You can ask a question by typing it into the Q&A box, as all participant lines are muted. Please feel free to submit questions throughout the presentation, but note that they will be addressed at the end of each presentation. Please use the chat box if you are experiencing technical issues, and we will work to resolve them as quickly as possible. The webinar is being recorded, and a link for on-demand viewing will be sent out to all participants after the session. A link to a short evaluation will also be sent out after the session, and we would greatly appreciate if you could take a few minutes to fill this out, as it will help us inform future sessions. I would like now to introduce our first presenter, Dr. Karen Gelmon. Dr. Gelmon is a senior scientist and medical oncologist with the BC Cancer in Vancouver. She was co-chair for the Breast Site Committee for the Canadian Cancer Trials Group and co-chair for the Scientific Advisory Board of the Ontario Institute of Cancer Research. She continues to do clinical research and is now chair of the University of British Columbia BC Cancer Research Ethics Board, as well as continuing to do clinical work. Dr. Gelmon will be sharing the advances of treatment and research for metastatic breast cancer. Thank you, Dr. Gelmon, for joining us today. I will turn the presentation over to you.
Thank you very much, Kathy. And thank you everyone who is joining this webinar. It's always difficult to know what people are going to want to see or talk about, but hopefully we'll be able to do this. Now, can you see my screen?
We can, yes.
Okay, so with that, I think what we'll just do is get started. This is a broad topic that I was given, and needless to say, I probably won't get through everything that you want to hear, but I'll try to deal with some of those things in the questions. So, treatments and research, what's my next option if this treatment stops working? Was the title I was given by Jen. Thank you very much. This is my conflict of interests. Let's talk about the spectrum of treatment for the patient. One of the things we realize is that cancer prevention and healthy lifestyle are talked about. Despite the majority of my patients, at least, having a healthy lifestyle, people get cancer. So that's not the whole thing. And I just really want to stress to people that we never want to be punitive. We don't have enough information about this now to know how to prevent cancers. But obviously, that's an area where we have to engage a lot of research. Cancer screening is looking to diagnose cancers early. We have cancer treatment, care, and follow-up, and that can include the treatment of early cancer as well as advanced cancer. And along with that is quality of life, survivorship, going all the way through to end of life. Through the whole thing, the important things are well-being. And obviously, one of the most important things through this whole journey is improving information and access. And we have to thank the CBCN for providing information in sessions such as this. One of the things that's happened for us in the health delivery side is we've realized that patient-related outcomes have to be a prime concern for care and clinical trials. So it's not just what the doctors think. It's obviously patient-related outcomes are important. How patients are feeling about treatments, what are their side effects, what are their concerns? This leads us to a question of measuring success. Measuring success in cancer treatment might be different for the different parties. Success to the oncologist might be things that we describe in clinical trials, such as progression-free survival, which just means how long before the cancer progresses, grows. Overall survival is how long does someone live with the cancer. Response rate deals with how about the cancer shrinking. When we get an effective treatment, we like it to be durable, for it to last a while. One of the hardest things for patients is changing treatments, but it's not easy for the oncologist to come in and say, your treatment's not working anymore, we have to change. And obviously, one of the successes is providing access to appropriate therapy for patients. Success to the family doctor might be supporting the patient, good quality survival, clear outcome goals, and then being able to support the patient along with the oncologist by understanding the clear goals and being able to deal with the other aspects of a person's care. Success for the patient, obviously, particularly in advanced metastatic disease, is a decrease in symptoms and improvement of quality of life. And many of my patients say, I don't want to just live longer, I want to live better. So increased duration of survival with good quality of life. People want treatment with few side effects. They want hope and continued options for treatment, and that's reflected in the title of this talk. And they want to feel safe and respected, and have their families feeling safe as well. These are the treatment algorithms in clinical care. There's early cancer, often what we talk about is adjuvant treatment. And in early cancer, we're talking about what's the risk of recurrence, what's the response with various treatments, and we're dealing with a curative intent. With advanced cancer, we want to deal with symptoms, we want to improve survival, we want to improve quality of life. With advanced cancer, we can't talk about cure. It's not ethical. Although there's a small group of patients who have cure, and in some series it's thought to be 5% or maybe a little greater. And although I have patients in my practice that I know have been cured of advanced cancer, because it's such a minority of patients who get cured, it's not really ethical to talk about it, even though many people may hope for it. What we have to talk about is improving good quality survival and having people live many, many years in synchronously with their advanced cancer without a lot of symptoms. It really is analogous to diabetes or heart disease, where we can't cure heart disease, but can we make people live longer? Can we have them die of something else? It's the same as with diabetes. Can we not have it overtake somebody? Cancer, because of its dire metaphors, often is seen differently. But what we're hoping with advanced cancer is we can turn it into one of those chronic diseases. So if we can't cure it, although we'd love to cure it, but if we can't cure it, can we have it not be a major issue? Can we have symptoms resolved and quality of life good? And then the final part is supportive care and end-of-life care, which I'm going to deal with a little bit at the end of my talk and which you're going to hear about in the next talk. So this is another way of defining the topic scenarios: curative, non-curative, or chronic. So we might not be curing, but we hope people live years and years and years. Palliative, where maybe symptom management, and end-of-life care, which is quite different. Some people talk about non-curative chemo being palliative. They have a binary idea. This is sort of three aspects, but a binary idea is there's curative chemo where you cure the patient, and there's palliative chemo where you don't cure the patient. And I think that's confusing semantically because many people think about palliative care as palliative care being just symptom management. And I think for many of us, defining the cancer topic in these three ways is easier than using a semantically difficult criteria. What's important to know is just as well as tumor heterogeneity, meaning that tumors are different, there's also individual heterogeneity. So different people with different cancers may have different reasons to be treated differently. And this is one of the questions that comes up all the time. People are sitting in the chemo room, they both have breast cancer, but they're getting very different treatments. They're both 58 years old with cancer in their bones, but they're getting different treatments. Why is my treatment different than someone else's? And it has to do with tumor characteristics. It has to do with exposure previously. It has to do with individual characteristics. And this is very important. What's important is we don't give the same recipe to everyone. At this time, there's often overlap in the recipe, but our goal with precision medicine or personalized medicine, our goal in the future is to try to personalize it more and more to understand both the tumor heterogeneity and the individual heterogeneity. Determining the treatment is not of advanced cancer. There's an L in there, sorry. It's not a black and white situation. So there might be very many options. And this is one of the issues when people get multiple opinions is they might not get the same answer because often there are differences dependent on how somebody's seeing the situation. So it's often not black and white and different opinions may vary. Let's talk for a few minutes about breast cancer classification. There's histopathological. What does that mean? That means it's how it looks to the pathologist under the microscope. Microscopes have been used for hundreds of years, and this is what happens. The most common kind of cancer is invasive ductal carcinoma, which accounts for 65 to 70%. Lobular carcinomas account for the next percentage, and then we get other kinds of carcinomas that are there. Tubulars are seen, they're very well-behaving cancer, mucinous. In the triple negative area, we have medullary, adenocystic, metaplastic. These are definitions that are based on pathological. We have subtype according to the immunohistochemistry. About 70% of breast cancers are estrogen receptor positive. About 15% of breast cancers have too much of a gene called HER2 and are considered HER2 overexpressing. About 50% of HER2 are ER positive, estrogen positive, and about 50% are estrogen negative. A very bad terminology, which we're trying to get rid of but is still there, is something called triple negative cancers. And those are cancers which are not estrogen positive, are not progesterone positive, are not HER2 positive, and account for about 15% of cancers. Subtypes defined by gene expression are shown there. This was first described about 20 years ago and is used a bit, but not widely yet in the clinic. And there we talk about luminal A, which are estrogen positive, very slow growing cancers, luminal B, which are estrogen positive, slightly higher growing, faster growing cancers, HER2 related, and then a couple kinds of triple negative, Cloudin low and basal-like. The final row, those circles you can see, are called circus plots. And what they're looking at is the mutation alterations by full gene expression, by genetic sequencing. What's important to note is the circle at the bottom, which corresponds to the estrogen receptor positive or luminal A, is very quiet. What you can see with the triple negative at the top is it's very busy. This is accounted for by more mutations in the triple negative than others. This also explains why those cancers grow quicker and why they're harder to treat. There are numerous different mutations accounting for the growth of the cancer. When we look at breast cancer subtypes another way, you can see the clinical standard, and this is the IHC, is the estrogen positive, the estrogen HER2 positive, estrogen negative HER2 positive, and the triple negative. This is looking at the luminals. This is looking at DNA expression. And now we're getting more and more and more different groups according to things called PI3 kinase expression. Suffice it to say, this is going to get more and more complex. And this is what I was talking about before. As we get more complex, as we develop drugs that are targeting these more complex areas, treatments are going to vary more with the tumor in the person. At this time, we're still stuck a little bit in the IHC, but we're getting more to seeing why treatments need to differ from one person to another. Really briefly, I'm just going to say treatment of early breast cancers for cure. You need multidisciplinary care with the surgeon, the radiation oncologist, the medical oncologist, the nurse. Providers that are necessary depend on the type of cancer, the age of the patient, the comorbidities. We've got surgery with lumpectomy or mastectomy. We've got chemo, depending on the type of cancer and the stage. We've got specific therapies such as anti-HER2 therapies. We've got hormone therapy if it's endocrine sensitive, and we've got radiation. All of these treatments given in sync for the attempt to cure the person and have them never relapse. In early cancer, it's a balance of the risk of relapse. How high is that risk of relapse versus the response to treatment? So somebody with a very, very, very low risk of relapse, even if they've got a HER2 positive cancer, may not get no treatment, or they might get endocrine therapy only. Somebody with a very, very high risk of relapse might get chemo plus HER2 therapy plus radiation plus endocrine therapy, and the duration of that therapy may vary. Let's talk about advanced breast cancer because that's really the subject today. As I've said, we've got an increased focus on good quality of life, not just prolongation of life. There's issues of toxicity versus benefit. Just because we can give it doesn't mean we should give it, because it might provide toxicity without benefit. Treatments must be effective and tolerable, providing survival benefit if possible, providing good quality of life, and toxicity issues must be manageable. These are the treatment algorithms for advanced breast cancer. Systemic therapy, which is therapy either oral or IV or IM that goes all around the body, depends on whether you're estrogen positive or estrogen negative. Estrogen positive with a long disease-free interval with a good response to prior endocrine is going to get endocrine therapy. And now we're adding in CDK4/6 inhibitor and PI3 kinase inhibitors. If it's estrogen receptor negative, if it's rapidly progressing, if there's extensive visceral disease that's rapidly progressing, or if it's progressed despite prior endocrine therapy, we might go to cytotoxic therapy to chemotherapy. If it's HER2 positive, we'll give anti-HER2 therapy. If someone has bone mets, we'll give bisphosphonates or denosumab. And now, if somebody has a mutation in the germline mutation, such as BRCA, something they've inherited from their mother or father, we might give PARP inhibitors. This is all very complex, and what I have to say is most important for this audience is this is changing all the time. And indeed, this has changed so many times, I have to keep changing this slide. Things like CDK4/6 inhibitors weren't available a few years ago. PARP inhibitors weren't available. Bisphosphonates have been available now for over 20 years, but they're changing which ones we give. Anti-HER2 therapy has been available now since 1998, but it too is changing, and we'll talk about that more in this session. When we look at how we individualize and tailor or sequence therapies, it depends on a number of individual therapies. Number one, the tumor factors. Is it estrogen positive? Does somebody have a BRCA mutation? Is there a targetable mutation, something that we can give a specific drug for? What about patient factors? What about the age, their menopausal status, their comorbidities? Do they have severe heart disease, making us need to avoid certain treatments? What's their performance status? And performance status just means how well are they? Are they getting up and doing normal activities or not? What about the availability of treatment? Hopefully no cost to the patient. What about their distance to the center? And always eligibility for clinical trials. We look at disease factors. How quickly is this disease growing? What are their symptoms? Is there a need for a rapid response? And we look at whether they've had prior treatment, prior responses, and what are the residual toxicities. And ultimately, we look at patient choice. What does a patient want? Now, again, just because a patient wants something, if it's not in their best interest, we might talk to them about it. But if a patient doesn't want treatment, that's very important. And one of the things that I think is very, very important for patients with advanced cancer is realizing they can make a decision to no longer get treatment or to continue to get treatment. And it's about them, not about their oncologist and pleasing their oncologist, not about their family. For a person with advanced cancer, they're the ones going through the toxicity, and they have to be a major part of the decision. Treatment of advanced cancer, as we've said, is to improve outcomes, and we have started to improve outcomes in a number of different subtypes. We've significantly improved survival for many HER2 positive cancers and estrogen receptor positive cancers. There's less improvement for triple negative, but some new improvements I'll talk about. Many advanced cancers, however, remain very resistant to treatment. It remains an incurable cancer for all but a very small minority, and we have to increase that number of patients that we can cure. New treatments remain necessary, and that's why we need money for research and persons to participate in clinical trials to try to improve treatment. These are papers that were published in the last couple of years that all show, an improvement in survival in estrogen receptor positive metastatic cancer. This is exciting. When I trained, we were told there was no chance of survival. Through most of my career, I've been told we don't have a chance of improving survival, but we've done it. These trials, all but one, are about the addition of CDK4/6 inhibitors, palbociclib, ribociclib, or abemaciclib, all of which are oral drugs and all of which are given with endocrine therapy. All three of these have been shown to improve progression-free survival and overall survival in patients with advanced breast cancer. We're awaiting more results. Unfortunately, not all patients respond, and not all patients keep a long-term response, but certainly these drugs are now standard of care for advanced ER-positive breast cancer. One of these trials, this trial, overall survival with fulvestrant, was looking at fulvestrant, an IM drug, a SERD, an estrogen degrader, plus anastrozole. It did show a benefit, but the majority of these patients had never had any adjuvant treatment, so very few patients in Canada fit into this group. But this did show a survival benefit. So ER-positive advanced breast cancer, the standard of care is now a CDK4/6 inhibitor and either an aromatase inhibitor or fulvestrant. For second line, there's very exciting data of a PI3 kinase mutation drug called Palliative and fulvestrant. About 40% of estrogen receptor positive cancers express the PI3 kinase mutation, and this can be tested both in blood and in tumor. This drug has just received approval in Canada. It does have some funding through a compassionate program, and hopefully it'll be funded through the provinces soon. Again, not all patients respond and not all patients are eligible, but there are patients who have a very good response, and I have a number in my practice. It does have side effects such as fatigue, diarrhea, rash, and sometimes hyperglycemia, but many patients tolerate it. If not PI3 kinase mutation positive, there is fulvestrant, there's everolimus, and there's also going to chemo, and capecitabine is a chemo which often works very well in estrogen receptor positive cancers. There are a number of other drugs that are being developed for this group of patients, but I'm not going to have time to go through all of these. Suffice it to say, we have made inroads in the last few years. What about HER2 positive cancer? It's a complex disease. We define HER2 positive cancers as having too much HER2, either by something called immunohistochemistry or something called Fisher-ish. It just means there are too many copies of the gene. About 15% of HER2 positive cancers, breast cancers are HER2 positive. And as I said, about 50% are estrogen positive and a 50% estrogen negative. They have many features, mainly that they grow very fast, and they often have tumor infiltrating lymphocytes, suggesting that immune drugs might be helpful, but thus far, although there's some responses, it's not been a home run. There are also about 2.5 to 4% of breast cancers that aren't HER2 overexpressing, but have DNA HER2 mutations and may respond to some HER2 drugs. And again, I have a number of patients in my practice who are responding to those. There are a number of exciting new treatments in HER2-positive breast cancer. I'm going to talk about the DESTINY trial in HER2-CLIMB. Sophia looked at a new trastuzumab-like drug that acts slightly different for those people who might be resistant to Herceptin. It's probably not going to make inroads. There's a number of other drugs that are there, including looking at neratinib, looking at the Patricia, which is looking at CNS progression. And there are also studies looking at the CDK4/6 inhibitors that we use in ER-positive cancer. I'm just going to mention a couple trials. HER2-CLIMB was a trial that many Canadian centers participated in, and it was looking at a new drug called tucatinib, which we had done the phase 1 trial of. Tucatinib was given with Herceptin and with capecitabine, and was compared to placebo, trastuzumab, and capecitabine. This is an oral drug. Patients were randomized in a 2-to-1 fashion. That means 2 times the number were randomized to the experimental arm than the placebo arm. And all of the patients had advanced HER2-positive breast cancer. All of the patients had received prior pertuzumab and prior TDM1. So they had been multiply pre-treated. This is the overall survival. I'm not showing you all these scans. Progression-free survival was different. But what's exciting about this trial was the survival was better. What's also very exciting about this trial is patients with either brain metastases or growing brain metastases were enrolled, and no other trial had enrolled patients with growing brain metastases. Tucatinib gets into the brain, and although it may not be first-line treatment for patients with brain metastases, it's looking like a good treatment for patients with recurrent brain metastases because they respond. This is a p-value, and when we see a p-value like this, we say it's very statistically significant. This is the hazard ratio, and what this suggests is that there's a 2/3 benefit of responding. So this is exciting data. This was published in the New England Journal of Medicine in December of last year. And there's a number of us Canadians on there. Phil Bedard from Toronto, myself, there's somebody else from Canada in here. I'll look, but there is somebody else from Canada, I believe, in here. The second drug I want to talk about for HER2 is something called trastuzumab deruxtecan. Like TDM1, this has Herceptin. It's got a chemo and this topoisomerase, and it's got a linker, which means that the drug is dropped off, or the drug attaches to the HER2. This linker allows it to be dropped off in the place where there are HER2-positive cells. It's like TDM1, but it has a different chemo than TDM1. It's got a different antibody ratio. It's got a different stable linker, and it looks like it might be even more selective, but we need to have further data. This was a single-arm phase 2. This is called a waterfall plot, and all the patients on this part of the plot have responded. So you can see that 61% of the patients had a response being below this line, and only a very few patients either progressed or had a less response. 11 patients had complete response. So this is exciting data. This trial was also published in the New England Journal of Medicine, and this drug is now being compared to TDM1 to see which is better. It's also being given in tumors that aren't HER2 overexpressing. Tucatinib has been approved by Health Canada, and trastuzumab deruxtecan is in the process. What about patients with germline mutations? What are germline mutations? Those are mutations that are passed on from mother or father to child. We always talk about, oh, it's not in my family, and indeed only about 10% of breast cancers are due to germline mutations. The most common germline mutations are BRCA1 and 2, which were described in the early 90s, but there are others such as PALB2, ATM, CHEK-RAD, and a number of others. We know that these germline mutations cause difficulties in DNA repair. What we also know about BRCA-associated breast cancer is BRCA1 occurs often earlier in young persons. It's often triple negative, and it's associated with ovarian cancer. BRCA2 is often slightly older. It's more often hormone positive. can be associated with ovarian, pancreatic cancer, melanomas, and in men it can cause breast cancer as well as prostate cancer. There are many similarities but different differences. What's happened in the last few years is there have been drugs that have been developed that exploit this idea of DNA repair. Olympiad was a study that looked at one of these drugs, something called olaparib, and compared it to physician's choice, most often capecitabine. And for those patients with BRCA mutations, showed that there was a benefit with a 3-month benefit in progression-free survival for the PARP inhibitor. This has also been shown for another PARP inhibitor called talazoparib. There was no overall survival benefit shown. This is more recent data, and what's exciting about this data is it didn't just show it for those patients with BRCA mutations, but those patients with PALB2 mutations also responded to olaparib. PALB2 mutations are not common, but they are associated with estrogen receptor breast cancer. And again, this is exciting because it leads to a future idea that this drug may be approved for those patients with PALB2 mutations. What about immune therapy? Immune therapy has been very successful in some cancers like melanoma, non-small cell lung cancer, renal cell cancer. Even in those cancers, it's only about 50% of patients who respond, but certainly there is a response. In breast cancer, triple-negative breast cancer is the best candidate for cancer immunity because it's got a high rate of mutational complexity. And there's also the presence of PD-L1 on TILs. What is PD-L1? PD-L is, you can think about it as sort of a mask. What happens is many people think about our immune system as sort of being like an RCMP that rides around on horses and gets rid of all bad cells. Unfortunately, the immune system is much more complicated than that. But part of the immune system is associated with PD-L or PD-1. And what PD-L or PD-1 does is the immune system sort of puts a mask over the cancer cell. So your innate immune system can't recognize those cells as cancer cells. What these PD-L1 inhibitors do is they take off the mask and they allow the immune system to recognize a cancer cell and then hopefully try to kill the cancer cell in association with drugs such as chemotherapy. We know there are higher rates of PD-L1 expression in both the stroma around the triple-negative cancer and in the triple-negative. And we also know that triple-negative cancer is one where we have very few options other than chemotherapy. This is what we call monotherapy. So just giving the drug, just giving the PD-L or PD-L1 inhibitor. These are two different inhibitors, atezo and pembro. What one can see is that many patients did not respond, but there's a small group of patients, about 18 to 20% in the first line setting, who do respond. And you can see these flat lines. This suggests a very long response. The median overall survival was only about 1.5 years. So there's not a great response for all of the patients, but there's a minority of patients who have a good response. Subsequently, there was a trial called IMpassion 130 that was reported about 1 year ago that gave that drug atezo plus a chemo drug called nab-paclitaxel. What it showed was for those patients who did express PD-L1 in the stroma, in the tissue around the tumor with triple-negative cancer, there was an overall survival benefit. At 3 years, 36% of the patients were alive versus 22%. This was exciting, and many patients are now receiving atezo plus Abraxane for this group, for this disease in first-line metastatic treatment. Unfortunately, just a few weeks ago, there was a report of IMpassion 131. It was exactly the same trial, but instead of Abraxane, it used paclitaxel. In this trial, there was no difference in the progression-free survival or overall survival. This was confusing. We claim to not know the answer. Is it because it was paclitaxel, not Abraxane? Was it because it was a particular group of patients? Was there patient selection? Was it luck that IMpassion 130 had the positive result, or was it bad luck that IMpassion 131 had a negative result? and we don't understand it yet, but it's going to cause a delay in the development of these drugs for triple-negative breast cancer. What we do know is triple-negative breast cancer is heterogeneous. What does that mean? It means there's lots of different kinds of triple-negative cancer. We know there's a role for chemo. We know if there's a germline mutation, such as a BRCA, there's a role for a PARP inhibitor. Immunotherapy, as I say, is confusing, but Abraxane and Atezo, or different chemos such as paclitaxel or gemcitabine cisplatin plus pembro, may be beneficial in the first line. And there are new drugs coming along. I'm only going to talk about one of those drugs, but one of those drugs is another immune complex or drug complex, conjugated drug complex. This is with something called TROP2. Sacituzumab is a new drug, and this was first shown in a phase 2 to have results. In the ASCENT trial, which has just been reported, there was both a progression-free survival and an overall survival benefit for the new drug versus standard of care, so chemotherapy that the physician chose. And this is exciting and is leading to the use of this drug and approval in the US and hopefully approval in Canada soon. So this may be a new drug for triple-negative cancer that's exciting. So let's talk about a treatment summary. In estrogen receptor positive, there's a role for targeted therapies, and there are great improvements. In HER2, we have very effective standard therapies, and standard therapies should still be used first, but there are exciting new treatments such as tucatinib and deruxtecan trastuzumab. In triple negative, immunotherapy may have a role with chemo in the first line, and there are new agents coming along. And most importantly, we're learning the differences in triple negative cancer, so that terrible term triple negative hopefully will be able to be discarded soon. And with germline mutations, we have PARP inhibitors. We are also doing PARP inhibitors plus immune agents, and there are some exciting results giving them with drugs such as Atezo or Pembro. What are the new directions for the future? We have to understand resistance to treatment. Why do some people respond and some people don't? We have to understand how to use new targets and new drugs. We have to understand how to use immunotherapy, and we're just scratching the surface. And what I believe is we're going to need to use multiple immunotherapies together in breast cancer, because breast cancer is complex. One of the other questions is, will early detection of residual cancer by circulating tumor DNA improve outcomes? And I'll talk about that. And we have to understand more about tumor heterogeneity and how a tumor changes over time. So just to finish up, there's something called circulating tumor DNA. That means that in your blood, you can measure tumor DNA, and you can look for both mutations in that tumor DNA as well as just its presence. There's a lot of work going on in this. It's not ready for prime time yet, but this is a study that I've done with my colleague Sam Aparicio in BC, where we're looking at a group of patients with triple negative cancer at diagnosis and seeing whether we can predict their risk of relapsing. What one can see is in those patients with blue who had no circulating tumor DNA, their risk of relapse was not very high compared to those who had circulating tumor DNA after surgery, where the risk was higher. That might tell us to treat these patients more aggressively with different treatments, with immunotherapy, with other treatments. It's going to tell us to do something different. As I said, this isn't ready for prime time yet, but is being used. And certainly we're looking for PI3 kinase mutations in circulating tumor DNA right now to try to give patients alpelisib if they are eligible. What about clonal evolution? This also is work from BC, but is being done elsewhere. What we know is that diagnosis of tumor may look like this. These are different populations. So if you think about a community, these might be the redheads, these might be the brunettes, these might be the blondes, these might be the gray, different populations. What you can see is after treatment, different top populations may survive the treatment better than others. So you might have different proportions of it. And what happens when they metastasize is those populations may be different. You can see that this population was there initially, but this dark green wasn't there. This is one of the reasons why we need to biopsy cancers when they relapse to understand what we're treating. And understanding this clonal evolution, how tumors change, is going to make us treat metastatic advanced cancer in a smarter, more rational way and individualized treatment more. This is something that we're studying. We're seeing whether fine needle aspirates can do this, and obviously circulating tumor DNA. So just to finish up, I want to just briefly talk for a couple of minutes about treatment of advanced breast cancer, which you're going to talk about after. Although we're increasing the survival of patients with advanced breast cancer, we have to integrate supportive care and end-of-life care into our patterns of care. We know patients worry about this in the middle of the night, and yet many oncologists don't talk about it. Many patients are scared to bring it up. Patients and families don't want to hear about it, but it's important we integrate it. We know that end-of-life care issues are complex. They vary with the person, with the disease state, with the timing. And communication and multidisciplinary care are keys to optimal care. What we know is that all oncology healthcare providers need the skills to talk about this, and we need to train students about this. When we talk about advanced breast cancer, there's a whole trajectory. There's the onset of symptoms, there's the communicating the diagnosis. For many persons, there's living with progressive disease, enduring sequential treatments, the symptom burdens, the relentless vigilance of having to come in for treatment visits. At some point, unfortunately, for most patients, there's a downward phase and there's a dying phase. And there often is a dissonance between active treatment and end of life, where maybe patients are feeling one way and the oncologists are feeling another, or families are feeling one way. Families want more and more treatment, and maybe the patient doesn't want more treatment, or maybe the patient and family want more treatment and the oncologist doesn't want it. We know there's phases and layers. So the palliative care involves living with a life-limiting illness, symptom management, maximizing quality of life, chemotherapy, radiation, surgery, all of these things, psychosocial response. There's end-of-life care, and terminal care is only a little bit about that end-of-life care. There are tensions of end-of-life care. As oncologists, we need to support hope in our patients. That hope, however, might be controlling pain and other symptoms, and hope can just be there. Patients often talk about miracles, and sometimes a miracle is being able to live years and years and years with good quality of life. The miracle might not need to be cured. We also have to balance it with reality. And one of the things early in my career that I had was I had a patient, young woman with metastatic disease, who was never did anything I recommended. I really liked her, but she never did anything I recommended. She had a very strong will. She did a lot of alternative therapy. She never took standard therapy, but I kept seeing her and we had a good relationship. And near the end of her life, when I visited her home, she said, I wish I'd listened to you about the fact that this was incurable. Her mother and sister lived in Ontario. She didn't speak to them. And what she said at the time of her death was that she would have reconciled with them if she'd really believed that it was the end of her life. So although we don't like reality, I think we have to tell people so people have autonomy to live their life aware of their time issue and to do the things they want to do, which might be spending their money or not spending their money or going on a holiday or telling their kids and their husband or their partner that they love them every day, even if they get to do that for a decade. Discussion about end of life is hard, but we need to talk about all of those things, including dying at home, dying in hospital, dying in PCU, natural versus medical assisted death. I had a patient a few years ago who filled out all her medical assisted death time and didn't use it for 3 years, but she really needed to do it 3 years ahead of time. There's issues for both the patient, their family, their loved ones, and who needs to be involved in these decisions. And there's obviously the spiritual and existential needs. I think the biggest thing is communication, and I think we all have to address these issues early. And addressing them early often means you then don't have to talk about them for years, but you've talked about them. There's balancing the need to know, the need for truthfulness, the acceptance of uncertainty, because all of us have uncertainty, and the need to maintain denial, hope, power, and autonomy and dignity. Denial gets a bad rap, but it often is the way that many people live and often is a good way of living. With our improved survival with advanced breast cancer, there's a balance between involving the palliative care. The classic role was we knew how people were going to do, but when there's new demands, with new treatments, we have more uncertainties in prognostication. We have broader goals of care. We often have new toxicities and new symptoms with all the drugs, including immunotherapy. One of the things I want to just mention before I end is when is anti-cancer therapy inappropriate? So many patients say, oh, they had nothing more to do for me. But sometimes anti-cancer therapy is no longer appropriate. And I think it's inappropriate when realistic goals are not discussed, when people think there's still a chance of cure and it's not, when you're not saying, we're giving you this treatment to try to decrease your shortness of breath, not to cure you, or we're giving you this treatment There's a small chance of success, but we're hoping it's going to decrease your shortness of breath. We have to talk about the potential for utility when treatment might be futile or might have a low chance of utility. We have to talk about treatment when it may be more toxic than beneficial. And we have to talk about whether it's going to destroy quality of your life. And many patients start on a treatment and then say to me, nope, this isn't worth it. It's destroying my quality of life. I don't want to do it, but they've tried it. When giving treatment is easier than honestly discussing palliation. And I think many times that's important. And when it interferes with diet, finances, time commitment, I have a number of patients who want to mortgage their house and spend all their money on ineffective treatments. And I have to be honest with them. Giving immune therapy as 10th line therapy has got a very low chance of response. And I don't want people to suddenly say they have no money because they've done something where there's no chance. If they want to do it and they understand it, that could be their choice, but they have to understand that. And it's sitting in a chemo room the way one wants to spend their last few weeks or months. So we have to support the symptoms of advanced breast cancer, and that's often with treatment. Those symptoms include pain, shortness of breath, nausea, anorexia, fatigue, anxiety, depression. That may be with treatments, but we have to be honest about it. The symptom profile changes over time, and we know that early in advanced breast cancer, treatment is a good time, but often stopping treatment before people get to a really bad quality of life time is important. This is from a book that I think is a profound book. This guy was a neurosurgery resident when he got lung cancer, and he died of his lung cancer. Both he and his wife have written extensively. And I think this sentence was interesting. He said, in a sense, nothing had changed and everything had changed. Before my cancer was diagnosed, I knew that someday I would die, and I didn't know when. After the diagnosis, I knew that someday I would die, and I didn't know when, but I now knew it acutely. And I think that's what we all have to be aware of. We don't know, nobody knows when somebody's going to die, but we know it more acutely with advanced disease. So in summary, outcomes have improved remarkably. The majority of breast cancer patients are cured with early treatment. However, too many patients are relapsing and dying, and we need more research. New interventions are necessary for prevention, diagnosis, treatment, and survival and follow-up. We all need to work together. And I have to thank the CBCN for these information sessions, because these really mean we're trying to work together. So thank you for your attention.
Thank you, Dr. Gelmon. I think you rose to the challenge on that very comprehensive topic. You covered an unbelievable amount of information in, I would say, a very short amount of time. We do have quite a few questions, so we will get to those in a minute. I'm just bringing up my screen here. So going back to the CDK4/6 inhibitors.
Oh, can you take down that picture? I hate that picture.
Do you want me to go like this? Is that better?
Okay, there's vanity.
So going back to the CDK4/6 inhibitors, a couple questions particularly around that. One, and I'm just going to bring up, I apologize, the chat box was up and now it's gone. So I'm having technical issues here. And I'll just read you the actual question because it provides some context. So Dr. Shapiro from Dana-Farber suggested that resistance to CDK4/6 inhibitors is not due to tumor mutation, but through a change in the signaling pathway as one cell and then crosstalk between cells. And also that perhaps a hiatus from treatment might break that resistance. Have your patients, or do you know of other patients who have either used CDK4/6 inhibitors with or without the same hormone therapy, or taken a bit of a hiatus, and how has that worked? Have you seen that in your practice?
So the resistance to CDK4/6 inhibitors is very complex. And what Dr. Shapiro is talking about is probably one mechanism where there probably is some resistance. There's also other crosstalk where other things like HER2 and that come into it. There's a number of different resistance mechanisms. What's interesting is despite a lot of research on this, it doesn't appear that we're very far ahead in understanding those mechanisms. And what we know is those mechanisms might be different for different patients. So it might not be the same for every patient. What we also know is it's different than HER2, where targeting HER2 continuously makes a difference. There are some studies going on right now looking at giving abemaciclib, which is a slightly different CDK, after palbociclib. And those studies are not suggesting yet that there's a big home run, but those studies might need to be done in different populations or in bigger populations. Right now, it's not recommended that you continue a CDK and just change the hormone therapy, although some people are doing that because there's not yet data to suggest that's an effective strategy. But like all things, I think that we don't know the final answer. And this is again another place where there's a lot of research going on, and we might learn more soon. It might be that it's going to be a small population of patients where stopping the CDK4/6 inhibitor and then going back to it will work at it, but we don't know yet.
Okay, so if a patient is looking to do that and wants to explore that option, is the best route to go try and find a clinical trial that's looking at exactly that, or that's the best mechanism for actually accessing that?
I think the best mechanism would be to try to find a clinical trial that's doing that, to talk with their oncologist, and to realize that there's very little data. One of the things you don't want to do is do something that's going to prevent you getting a more effective treatment. So if somebody has progressed on a CDK4/6 inhibitor and let's say has a PI3 kinase mutation, we've got good data right now that those patients might respond to alpelisib. So I would do that first, not do the CDK4/6, do what's tried and proven right now. But it might be that going on a clinical trial or somebody without without an alpelisib, a role for alpelisib, it might be a good option. So we don't know yet. And I must admit that I think it might be a high bar. It might be something that, is only going to be effective for some patients.
It goes back to your earlier point around how really personalized this ends up being for each individual. And then while we're speaking about clinical trials, so there was another question really looking at the context of now that we're in this virtual healthcare space that patients and physicians are so frequently accessing in this COVID era. Have you heard of sort of that expansion within clinical trials to make them a little bit more accessible virtually? So is there the option to participate in clinical trials for patients who may be at a much greater distance, or maybe who can only access a cancer center that's a couple hours away from them, as opposed to trying to drive to you in Vancouver that might be 8 hours away? Is there a shift in the clinical trial space, or is it still very much you have to be able to physically access the center?
So that's going to depend a lot on the clinical trial. You have to realize that one of the big things with clinical trials is if it's an experimental drug, patient safety is the first thing around ethics. Are we going to protect patient safety? So if it's a phase 1, an early trial, or a phase 2 of a new drug where we don't know all the side effects, safety is going to be most important. So for example, I talked to you about trastuzumab deruxtecan. One of its side effects is an interstitial lung disease that people have died of. It's a very significant toxicity, and although it's in a minority of patients, you don't want someone to have interstitial lung toxicity. And I don't know how well you can assess that necessarily over a video link or over the phone. So if it's an early stage clinical trial, it's going to be hard to do them simply by video link. For many of my trials, we have patients who are on them who we see intermittently by video link and sometimes face-to-face. So we don't do all the trial visits face-to-face. And most trials have had this COVID change where we don't do all the trials face-to-face, but we still need to see the patients at some point for their safety. That includes phase 3 trials. I just saw somebody yesterday who had driven 2 hours in to see me for an adjuvant trial of a CDK4/6 inhibitor, the NATALEE trial. I'm doing some of her visits virtually and some of them face-to-face to avoid her driving. So I think we're sort of doing a hybrid thing, but I think patient safety has to come in. I know there's a situation right now where there's a new drug being tested in Seattle, and a patient from Vancouver obviously can't go to Seattle for that trial. And that is obviously a problem. So, but that trial is again an early trial, and they're not letting this patient do it virtually because of safety issues. So I think hopefully COVID won't last forever. There are some changes with COVID, including a lot of virtual visits and missed visits. There are some changes with COVID where you don't have to get your scans as often, but I think patient safety still has to come into it.
Thank you. I think that that speaks to the need to still have some of that monitoring and the in-person visits. So another question around actually for ER positive and HER2 positive breast cancer. And in terms of, do you think it's important to continue to check the status of those breast cancers if there is progression? Should that be standard of care?
Yes, I do. And that's a good question because it shows somebody was listening to the part about clonal evolution. Clonal evolution means that the tumors evolve and change. So you have to continually, if you have somebody who's got an estrogen receptor positive recurrence, you've biopsied the recurrence. And I have to also say, if somebody's got a recurrence in somewhere where it's not safe to biopsy, you don't do it. But that's why we're testing circulating tumor DNA and fine needle aspirates to see their utility, whether they can be used instead. But if you've got somebody who's not responding to a CDK4/6 inhibitor, you might want to say, is this still HER2 ER positive? Because the majority respond. You might want to rebiopsy and say, oh no, it's turned triple negative. If you've got somebody who was previously HER2 positive and they're not responding to HER2 drugs, you might want to rebiopsy because they become triple negative. So I think when you're not responding, it's important to continually do it. If somebody's got a typical response and is doing well, you don't have to keep doing it. But at a time of progression, you might want to rebiopsy. And why is that important? To know what we're treating and to provide the person with access to the appropriate treatment.
Wonderful. Then speaking of testing, moving into, and I know in Vancouver was the POG trial. So when do you think that whole genome sequencing of the tumor fits in? How does that play in, especially in the MET space?
So I think there's a lot of discussion on that. And there's Octane and there's other studies in Ontario and all across the country. There's studies in Montreal going on. I think there are sort of three issues. Number one is doing the whole gene sequencing and finding a target, and many tumors don't have a target. The second thing is you have a target, but there's no drug. Or the third thing might be you have a target, there's a drug, but there's no access to the drug. So it's only a minority of situations where we find a target and we have a drug and we have access to a drug. And in those situations, whole genome sequencing has been a real godsend to a lot of people. But unfortunately, for very many people and for very many breast cancers, there aren't targets. There's a trial that's run through CCTG called CAPTURE. And what we're looking at is foundation medicine sequencing of blood for circulating tumor DNA. And I've had an awful lot of breast cancer patients go on that where their tumors are very quiet. There isn't a target. And, I have to say there isn't a target on October 29th, 2020. Hopefully there'll be a target that we can find in, 2 months or 6 months or 6 years time. But right now, we've got to find more targets. So whole genome sequencing right now is limited in terms of breast cancer understanding the targets and having the drugs for the targets. That doesn't mean we shouldn't still be using it. And studies that are being run across the country looking at this are extremely important. But I also always have to say to people, I hate to disappoint you when your foundation medicine or when your POG or whatever comes back and you don't have a target, because often there isn't a target.
It sounds like now then one of the best ways to access this, if this is something that patients are interested in, is to try and connect with one of these trials that's making these fairly expensive tests accessible to patients. Exactly. Moving to a metastatic patient who has I apologize. Let me start over. Where the cancer has metastasized to her skin. Just asking a question around whether or not someone with that specific metastases may be a good candidate for electrochemotherapy that they have in the US, and whether you could speak to that.
So skin metastases are more common in other cancers such as lung cancer than in breast cancer, but certainly they do occur. The issue for something like skin metastases is it just in the skin one little area, or is it more widespread? If it's skin right over the chest wall, right where the breast cancer was, it might be leftover cancer. And in that situation, local therapies such as radiation, surgery, cryotherapy, or some of the therapies that are available in the States, such as local chemotherapy strategies, might be good. In the majority of cancers, when they metastasize to the skin, particularly if it's outside the area of the breast, it suggests that they're in the lymphatics or in the blood system, and they're more widespread. Although local therapies such as surgery or radiation or localized chemo might be helpful, it's not going to do anything for the rest of that cancer. So the important thing to know is this cancer elsewhere, or is it just local? Is it systemic? Does it need systemic treatment? How's the rest of the person? Local therapies might not get rid of the systemic, but they might be a way to decrease the time before it progresses. And I see that there is a question about a metastasis just in lung or lymph nodes. Can there be a chance by cure by surgery? And that's very similar to this skin question. In things like sarcomas, and sometimes other cancers, it looks like removing the lung cancer metastases does make a difference because they seem to be less systemic. In breast cancer thus far, there hasn't been as much success with just removing them. If it's just local lymph nodes in the armpit, in the side where there was cancer, sometimes there is success, particularly if it's given along with endocrine therapy. But lung metastases, it's not been as successful. It's really still an experimental thing to do lung metastases to just remove them, or skin metastases. So I think it partly depends on the patient, on staging, is there any other cancer, on where those local metastases are, on what prior treatment they are. And again, as we've said millions of times, it depends on the subtype. Is it triple negative? Is it HER2 positive? Is there another option for therapy?
Right, thanks, Dr. Gelmon. It sort of towards the later part of your presentation, we were speaking about switching therapies and decisions around when to continue or stop therapy. And so this question, Kim asks, outside of patients requesting to stop therapy, what are other signs that you look for to halt or switch therapies? Are your decisions based solely on the latest scan results?
So I think it's putting it all together. When we talk about halting therapy, we have to talk about, number one, how's a person feeling? And that's always the first thing. So scans are secondary, but how's a person feeling? If they're feeling great, fine. But if they're not feeling well, regardless of what their scan shows, it may be time to stop treatment because of toxicity issues, often cumulative toxicity. The more treatment, the more cumulative. If somebody's feeling fine, but their scan shows progression, then it matters where the progression is and what the subtype is. If it's significant progression, then you might want to change or halt therapy. If it's a minimal amount of progression, the person's feeling fine and it's estrogen receptor positive, slow growing, you might leave it for a bit and then change therapies. So it really, really depends. If somebody does have scans that are showing massive progression, then it's not appropriate to not talk about it with the person and say, you've got massive progression. This treatment isn't working. I don't think giving you more treatment makes sense. And at that point, the person and their oncologist and other healthcare workers have to decide, are there other treatments that might be not very toxic and worthwhile that should be tried or not? So that, so there's lots of reasons to stop treatment, some of which is just toxicity. I sometimes have patients, I had a patient this summer, a male patient with HER2 positive breast cancer, who really wanted to get time off and go on a 6-week holiday. He went on a 6-week holiday, his tumor exploded. He was in terrible pain when he came back, but he'd had a great holiday and he didn't regret what he did. And he's now back on treatment. So sometimes people just need a holiday and we always have to respect that.
Thank you. I think that's a great point in terms of, again, that personalized piece and having that conversation with your healthcare provider and individually about what that patient's priorities are. So we have time for probably one more question here. And this one is around, supposing the cancer burden is low and the patient is in relatively good health, if the patient is well educated about the risks and requests for a treatment with curative intent, can they get it? And this, I guess, comes down to some of the access issues and what's available to patients.
So the question there is, nobody is going to not give somebody a treatment that's got curative intent. And access issues are usually not a big issue. So in Canada, although we don't get all of the drugs right away, most things that cause cure we're able to get pretty readily. So nobody is going to hold somebody off a curative treatment. I think what we're talking about more is palliative treatments, treatments that don't have cure. And I think there, again, it comes down to something that we were talking about earlier around veracity and honesty. Sometimes people don't realize treatments aren't curable and they are insisting on them before a goal that might not be realistic. So that's where our communication skills and our honesty, and as I said, there's this difficult balance between hope and reality. You don't want to pull the hope away from somebody by saying, oh, sorry, this is incurable, but you also have to give them the reality. You don't want somebody going out and claiming they can't get a curable treatment and that nobody will give it to them even if they're willing to pay, when it was never a curable treatment. So we just have to be honest. Most of the treatments for cure that are given in early cancer treatment, we do have access to. The place where there's a slower uptake is often in the advanced setting.
Well, and hopefully we'll see some of those wait times reduced. We'll keep working towards that. That, I think, concludes our time with you, Dr. Gelmon. Thank you so much. We really appreciate you sharing all your knowledge with us, and it was an incredible session. Kathy, I will turn it back to you.
Firstly, I want to thank Dr. Gelmon. Thank you, Dr. Gelmon. Wonderful presentation. Great questions, great discussions. Thank you.
Thanks, everyone. Bye now.
Bye-bye. Thank you. Okay. So I would now like to welcome Dr. James Downar as our next presenter. Dr. Downar is a critical care and palliative care physician at the Ottawa Hospital. He is also the head of the Division of Palliative Care at the University of Ottawa. Dr. Downar is involved in many research initiatives at the Ottawa Hospital Research Institute. He graduated from McGill Medical School and completed residency training in internal medicine, critical care, and palliative care at the University of Toronto. Dr. Downar, thank you for taking the time to share your insights in pain management and palliative care with us today. I will turn the presentation over to you. Thank you.
Thank you so much, Kathy. Can you hear me okay?
Yeah, very good.
I just want to make sure the sound is good. I have a little munchkin running around here, so I have to go with the, I can't go with the normal speaker approach. So I'm just going to share my screen here and go to full screen. And there, can you see my full slide now?
You can.
Perfecto. All right. So yeah, and I think obviously I don't know if that last question was a plant, but was a very good segue into what we're about to talk about now. And I'm gonna, I was asked to give this talk, sorry, and I understand it's about 40 minutes long. And it's always funny, people ask you to sort of try to distill your entire job into, a 20 to 30 minute talk, which is, again, very understandable. I think a lot of what I do is probably not very interesting here. So, but I am going to try to give sort of an overview of some of the big considerations and options around pain control. I don't want to go into insane levels of detail about medications, receptors, and pathways, simply because I think that probably that will cause a lot of people to go to sleep. But I am prepared to answer questions, and I've tried to leave a good amount of time at the end for questions. So if anybody does want to dive a little bit deeper into anything, then that is that option. Okay. So I do want to disclose that I have received some support from different organizations, including the Associated Medical Services through a fellowship. I've had grant support from Boehringer Ingelheim, but I'm not going to be discussing any of their products here today. And I've had speaker fees and honoraria from Medtronic, Novartis, and Juul Incorporated. Not going to be discussing any of their products today. There are other sources of potential bias, and what I'm going to say to you today, one of them is that I'm currently involved in a helping somebody do a randomized controlled trial of cannabinoids, so cannabis-based medication. I am going to be talking about cannabinoids today, but I won't make reference to specifically any products. I'm also involved in an early phase study of a medication called dexmedetomidine, which I'm not going to be mentioning, but just wanted to mention that that is all out there. So the main outline points that I wanted to go over today, number one, I want to talk about some pain and some types of pain. I'm going to talk about the traditional approach to pain management, which still is largely in use today. And then I want to talk about some of the newer approaches and also touch on some of the challenges to pain management based on intersecting issues. Finally, I'm going to transition into what palliative care is and what palliative care isn't. And I'm hoping to save a good amount of time at the end for questions and answers, because usually people have a lot of questions about palliative care. So pain is a very interesting concept in medicine. So cancer, you can scan for it, you can see it, you can cut it out, you can put it under a microscope. Those are all things you can do with cancer. heart failure, you can look at the heart itself, kidneys, you can do all kinds of blood tests. Pain is a bit different because, of course, there's no actual gold standard for pain. Pain doesn't necessarily show up on a scan. It doesn't necessarily show up on a blood test or anything. It's something that is truly related to something that the patient reports. And one of the adages in palliative care is that the pain is what the patient says it is. And that's a really, really important concept to grab a hold of when you're trying to treat pain, which is that you really cannot begin to treat pain or get on top of pain control without a lot of input and help from the patient. So there are many different types of pain, and sort of classic descriptions which people talk about would be, first of all, dividing it into the two worlds of what we call nociceptive pain and what we call neuropathic pain. I think that the distinction between the two we've come to understand is probably not all that clear, but it's still helpful conceptually to think about. So if I were to simply explain the difference between the two, nociceptive pain is essentially pain fibers, pain neurons, doing what they're supposed to do, which is whenever you have an injury or a mass or something where it's not supposed to be, you should be receiving some sort of sensation from your body, making you aware of that. Pain is a vital thing in keeping us alive. We need to know when we're being injured. We need to have, if we've been injured or something, if a snake will bite us and our previous experience being bit, we're gonna remember that pain and not wanna go through that again. So pain serves a vital function in human life. That obviously, when someone has cancer, pain neurons working as pain neurons are supposed to work is a major source of pain. But there's another concept of what we call neuropathic pain, which is in a simple way of thinking about it is when the nerves themselves are damaged. And then what happens is you start getting pain sensation that's actually not necessarily related to something that's happening in your body so much as just the nerves themselves. So nerves can be damaged because of radiation. They could be damaged because of surgery. They could be damaged because of chemotherapy. All of these things will affect how nerves work. And if you have damage to your nerves, you may have very serious symptoms, like very serious pain, but someone tries to look at, what's causing that pain, and you actually can't find anything, or you'll find at most a very trivial mass or injury that would, something that you wouldn't think would be enough to explain it. So that notion that sometimes you're dealing with nerves functioning the way they're supposed to, and then sometimes you're dealing with nerves that are not working the way they're supposed to, and how you might approach that is very different. Now, I mentioned that the two seem to be a bit more overlapping and related, and that's really important because in cancer, most of the time, it's a mixed pain. So you have some components of nociception, some components of the nerve actually picking up what's there, but then sometimes it's an exaggerated or beyond what you would expect for the injury pain. And that's what we often refer to as mixed pain. And that's a really important concept. Also important to know that if somebody has chronic untreated pain, even if it's nociceptive, what happens to the neurons is they start to actually get damaged. When the pain pathways are being activated constantly, those nerves that travel up your spinal cord actually do get damaged. And that actually results in people feeling more pain and sometimes being less responsive to pain medications, which is an important principle we're going to come back to, which is why don't leave pain. Don't let it alone. And leaving pain uncontrolled for a long time is usually a bad thing. There's incident pain, which I want to talk about, which is sometimes when people have pain that's kind of constant and always there, and they move around and they're sort of there with it, versus somebody who might have pain that really comes up mostly when they move or do a specific action. So if somebody has, for example, a broken bone, it might not hurt at all until they move or try to do something with it, and then it hurts, and that's related to an incident. And then the most important concept probably of all that we embrace in palliative care is the concept of total pain. And total pain is the idea that really pain that you experience as a human being is a lot more than just how the neurons are firing in your pain pathways. That actually it relates a lot to your mood, to your thinking around what's going on inside of you, to emotions that you're having. Sometimes there are actual pain behaviors, and societally in some cultures, expression of pain and endorsement of pain is different than in others. And so what we perceive may be very different in this notion of this kind of pearl of layers on top of what may be only for which tissue damage is only a small part. And that's a really important concept that, whenever somebody has, for example, an advanced illness or an incurable illness, the same pain might be experienced a lot differently for the fact that the person knows that perhaps they're dying, and that obviously affects how they feel that pain. When we ask people to take a pain history to understand the pain, we ask them about the OPQRST. So when did it start? What makes it come out? What makes it go away? What is it, the quality and the quantity? So what does it feel like? So sometimes people talking about just sort of a dull pain versus like a stabbing or electrical pain or like fire can tell us a little bit about what might be causing it, and whether this is a neuropathic pain or a pain that's inflammatory, where certain specific medications might be helpful. And that's why sometimes people come in a lot of pain and they want to know why the darn doctor keeps asking them all these silly questions. Well, unfortunately, we need those questions to help us, guide us towards specific therapies. Whether it radiates or shoots down. So sometimes when nerves are injured, you may feel the pain shooting in a certain place. And what's also important is that when not all of your body actually has pain neurons in it, not all parts of your body have pain neurons in them. So for example, within your abdomen, many of the organs like your intestine, your stomach, don't actually have pain nerves in them, but the bag that surrounds it all, the peritoneum, has a lot of pain nerves in it. So when you feel pain in your abdomen, sometimes it's very non-specific. It's hard to know exactly what's going on. You can't really feel what part of your intestine is hurting. You just know there's something owie in your tummy, versus if somebody sticks a needle in your finger, you know exactly where that pain is. So the body is wired differently, and that's important to appreciate. Obviously, the severity and the timing can be very helpful. Just want to flag some of the intersecting issues that are coming up now more and more in how we treat pain. And probably the most important is this notion of opioid use disorder, or sometimes known casually as the opioid crisis. But related to how people may misuse their opioids. So some people obviously, frankly, abusing it, injecting it. Sometimes people get had previously been on opioids, and then they're transitioned over to chronic pain and have addictive behaviors. Sometimes people using these drugs recreationally. There's a big intersection with mental illness, with vulnerability, with structural vulnerability. And so this has become a really important area of study for us here. That becomes very important when someone arrives at the end of life, and now we're trying to use these drugs to treat their symptoms. Not surprisingly, those drugs might not be all that effective if they've been sort of using them chronically for other reasons. And obviously how one copes with the situation around them. If it becomes now a tool that you need, the tool is actually less effective. So many may be aware that the government and professional societies put in place guidelines and new safeguards to try to reduce prescription of opioids in the hope that might blunt the opioid crisis. I'm sorry to report that it did not. And in fact, it seems now to have had almost exactly the opposite effect. So here I've shown you a graph of purple is emergency department visits, orange is hospitalizations, and green is deaths over time. So in Ontario, those restrictions came in around 2016, mid-2016. And you can see around that time, we had a slowly growing number of emerge visits, hospitalizations, and death. And since the restrictions on prescribing of higher dose opioids came into place, we saw a dramatic, at one point, I believe it was an 8-fold increase in the emergency department visits, and a 2- to 3-fold increase in deaths. So it's probably not true to say that prescribed opioids are necessarily feeding this crisis. And more importantly, taking them away forces those who are addicted to actually find their opioids elsewhere, which is probably the most dangerous thing they can do. And then getting their hands on street carfentanil and other very, very potent medications that actually can stop them breathing, and which seems to be responsible for most of the deaths. Those who have psychological distress, mental illness, particularly as they're getting nearer to the end of life, there's a concept of what we call chemical coping. So someone seek out these medications more as a sort of escapism. And that's challenging, of course, because it's not really the way to treat psychological distress. But sometimes people are very unwilling to engage around mental illness and mental disorders. And this is kind of what we're left with, which is really unfortunate. And then increasingly, we're becoming aware of how the problems of treating pain in those with cognitive impairments. So people with advanced dementia, or other cognitive disorders where they're not able to necessarily report their symptoms. You just have to try to figure out or infer whether they're in pain based on your observation of them. And of course, one of the big advantages we have in palliative care and in treating pain is what's known as the placebo effect, or what's sometimes what we can sometimes see is what's called an expectation effect, that people know that they're going to get pain relief from this pill. They get the pill, they feel better. And often I talk to people like, how long did it take before the pill makes you feel better? And people say, oh, it's 5 minutes, 10 minutes. I already feel pain relief. And that's great, but I can tell you that, from a scientific basis, there's absolutely no way that pill has done anything to you in the first 5 minutes. It just hasn't even been absorbed. So again, which is fine. I don't mind. I get paid whether it's the placebo effect or the pill, but realistically, I think that's a phenomenon I can take advantage of in certain people to get their symptoms better. But for somebody who doesn't really know who I am, what I'm doing, and what this pill's about, they're not necessarily going to get those effects, and so that's a problem. When we're treating pain, traditionally, the history is everything, as I mentioned. It's everything's got to be about what the patient tells you. You want to treat promptly according to severity. You don't want to leave things lying there. In the old days, people used to go for no pain as the target, just eliminate all pain. And I remember one of my mentors actually walked around with a pin on his lab coat that said, just had pain and a big X through it, which is not really, I think, a realistic expectation, frankly, with really severe pain. We don't really talk about total pain elimination anymore. We talk about management, and it's not hard to get pain managed. It can be very hard to get pain eliminated, and setting that as the expectation can be very distressing for people when it doesn't happen. Important thing is that we try to get people to the point where we are putting them on standing medication. So if somebody's got constant pain or got a lot of pain going on all the time, it's probably a good idea to keep a fairly constant level of opioid in their system, not going up and down, up and down, up and down, and just telling them to take pills whenever they feel like it. That's actually a very bad thing, because then they get the sort of extremes of pain, and of course, extremes of drug level in their system, which is not really what we're aiming for. The strategy we found is better to stay ahead of the pain. You end up using actually less medication overall, and certainly you feel better. So that's the way to go. You obviously want to monitor and titrate to effect. People have these concepts of arbitrary numbers, like, oh, I don't want to give them more than 10 milligrams of morphine. I don't want to give them more than 20 or 30 or 40. What we know now is that people are very variable in how they respond to opioids. You can use dramatically different doses to get results in different people, and side effects as well with different people. And we're learning a lot about the genetics of how people respond to opioids. And the bottom line is that there should really be no notion of what number you're using as being too much or not enough. You give enough to get you go up until you get either symptom relief or you get side effects, which would cause you to scale back. And that's generally how we approach it now. And then using adjuvants, so non-opioid medications. I'm going to talk about those. Of course, I've put a heavy emphasis on pharmacological treatments and medications. There are some non-pharmacological treatments I'm going to talk about too. It would take a long time to go through all of the different pharmacological options out there, but opioids, of course, the one that most people would be familiar with are morphine and hydromorphone, which are probably the two most commonly used in Canada. Oxycodone has kind of fallen out of favor a little bit because of all the press around OxyContin and that sort of thing. Personally, I still find it can be useful at times, but one of the things that limits it for me is that we only really have it available orally. So I prefer medications where if somebody's not able to take the oral route, I can give it by injectable, and it's a fairly easy conversion. So that's why I personally use hydromorphone or morphine. Good old-fashioned Tylenol is a big help for us. It's probably one of the safer medications known. It does have problems as one gets very old or with very advanced liver disease, but it's about as safe as a medication is likely to get, and can be a very good adjuvant, a good little additional medication to go along with the opioids. The other thing, the secret that don't tell anyone, but anti-inflammatories can also be very, very effective too. And some of you may be familiar with steroids like dexamethasone, and particularly recently because of COVID, dexamethasone's made some headlines, and certainly in the treatment of Donald Trump recently, and seeing some of the side effects it had on him has made some people somewhat question whether they would want to go on dexamethasone. But I assure you that it is quite a safe medication, and it can be very effective for helping us treat many pain types of syndromes as people get more advanced illness, and we like it. I think non-steroidal anti-inflammatory drugs are going to put my kids through college, frankly. They're very effective for certain types of people who get pain associated with inflammation, a lot of head and neck cancers, or you see inflammation in the neck, and you know, people try to take a lot of morphine, hydromorphone, without great relief, but then putting them on some ibuprofen or even a little bit of ketorolac for a day or two can be really, really effective. For the neuropathic pain where the nerves aren't working well, there are lots of medications that we like to turn to, and some of you may be familiar with drugs like gabapentin or pregabalin, and these are medications that are, you know, they're probably reasonably effective. The chronic use of them has been questioned now as how safe it might be, and does it result in long-term problems. Certainly these medications do have side effects, and you need to be aware of those. But on the whole, I think they're pretty well tolerated, and they do give some pain relief in the palliative context. Antidepressants like nortriptyline and the newer duloxetine can also be a really nice medication to add in there. Ketamine is available as well now and becoming increasingly fashionable for various different reasons to try. It can be a very, very effective thing to use acutely for somebody who's having like a pain crisis from neuropathic pain. The only issue is that if we want to give it over long term, we have to give it via a pump, and it tends to be less effective over time. So methadone I'm going to talk about again later, but methadone is also making a bit of a comeback as a medication that can be very effective for complicated pain. For non-pharmacological approaches, radiation, people are getting much, much better at using and targeting radiation effectively to zap nerves and to try to zap tumors to shrink them just a little bit, take the edge off, so that pain might get better under control. And then there's, of course, neuroablation, or what some people call nerve blocks. So you can either get radiation, or an interventional radiologist will actually put needles in and find if there's like a bed of nerves. So one great example would be pancreatic cancer, which is the pancreas growing and stretching the nerves. And pancreas normally sits in a bed of nerves that gets stretched and cause a lot of pain. And you can actually go in with a needle into that bed of nerves and kind of just block them all with a medication, or ablate them for several months. And people get almost complete pain relief from that, which is really nice when you can do it. I'm just, in the view of time, going to move along here. Many of you probably have 101 questions about cannabinoids. Most of us do. Cannabinoids, has been a lot of interest in them. The studies do suggest potentially that they improve pain control. A lot of people have done studies where they look to see if it reduces the use of opioids, and it does potentially reduce the use of opioids. Whether that's a good thing is another question, but certainly it seems to do that. Not really sure about the effects of its chronic use yet. We don't obviously have enough data to study that. And of course, tons of questions about which preparation do you use. So probably the most common question is, do you use the THC, which is one that people think has some good effect on pain, but also causes the psychotropic effects and gives you the high and the buzz, versus CBD, which probably also has some good pain relief and maybe a little less likely to cause the buzz or the high, but even then a little bit probably does. Do you use them in combination as they're found in many different strains of cannabis? And of course, the actual strain of cannabis, all the strains of cannabis are different in terms of what combination they have, which is a challenge. What dose do you use? What frequency do you use? And of course, for people who may have tried recreational cannabis and found it way too strong, well, the sort of illicit economy, or say the recreational illicit use of cannabis, has driven people to make insanely powerful strains of high THC cannabis, which many people would probably not be able to tolerate due to side effects. And if that's your only experience with cannabis, then not surprisingly, you might not want to try it. There's a lot milder versions that may be quite helpful for different symptoms. We are currently engaged, as I mentioned, in a study looking at different preparations for any cancer-related symptom. And we're hoping to have some better data. But right now, I was just a co-author on a paper, a study that suggested, or a review that was suggesting that we really too early to tell. And the big problem, of course, in Canada has been such a rapid change in the legal status of cannabis. So it went from illegal to prescribable for a couple of years, to but the rules were quite challenging and many people didn't really know how to navigate the system. And now it's just ubiquitously available, and you can go to these dispensaries and buy pretty much anything you want. So that's largely driven people to move forward. And now we're at the point where, by the time you've seen a patient, chances are if there's somebody who's willing to try cannabis, they already have. And so that's helpful on the one hand, but if they haven't tried the right stuff, then it's less helpful. We are moving away from the chronic use of traditional opioids, and that's sort of part of the guidelines, because it does seem to have chronic damaging effects on the neurons themselves, and trying to get people off of opioids if they're going to be chronically ill. That's different than in a typical palliative setting where we don't expect somebody to improve. Then we're less concerned about getting them off of the opioids. But newer, old opioid like methadone, which is more effective, less likely to be addictive and very effective for pain, is one option. The other option that people are loving now is a combination of buprenorphine or naloxone. Buprenorphine and naloxone, I should say. This is a medication that's what we call a partial agonist. So you can take it and take it and take it, but eventually you hit a ceiling effect. So it's very unlikely that you could really overdose on this medication. And because it appears in a mixture with naloxone, it can't be melted down and injected, because the naloxone is an antidote to the buprenorphine. So it doesn't work if you eat it, that you absorb the drug, you don't absorb the antidote. But if you try to inject it, you get the drug and the antidote, and nothing happens. And there's been a lot of interest in using this more as a first-line medication. Again, I find in general some pearls here that refractory intolerable pain is pretty rare. You always have to look at the big picture. One thing that people often do is they tough it out, right? They just like, I don't need the opioids, doc. This isn't too bad. I can manage pain. Probably the best way, if I wanted to get somebody addicted to an opioid, what I would do is I would tell them, don't take your opioid. Let yourself get into a lot of pain and just try to tough it out. And then at the last second, when you decide you can't tough it out anymore, then take a lot of opioid at once, suddenly get the pain relieved. Then don't take any more opioids for a while, let the pain come back and get really, really bad, and then take the opioids again. That is exactly how you can get an animal addicted to opioids. And unfortunately, that's exactly how most people try to take their opioids. So I try to say, look, the best thing to do is try to get ahead of the pain, keep a low level of it in your system. Don't do dramatic shifts of any medication, and try to stay ahead of your symptoms. That's probably the best way to treat your pain, but also stay away from getting in trouble. Opioids are not really that dangerous when it comes to treating cancer pain. There's really no evidence to suggest that it is, especially when it's prescribed by somebody as a palliative care provider. So please don't be afraid of them. Some people are afraid of the side effects of opioids, making them confused, et cetera. Don't forget that delirium can also be brought on by pain and untreated pain. So again, both overtreatment and undertreatment can be problems. But also don't neglect the non-opioid therapies, because they can be very effective. I want to say a word about complementary and alternative therapies, because many people do talk about them for different reasons, including palliation and these sort of newer preparations of things that many of them I haven't even heard of. Generally speaking, if you're trying something or thinking about them, don't hide them from your treatment team. You almost never have to choose between taking those things and your traditional medications. But always ask yourself, what is the evidence for their effectiveness? And I think this is a fair question also to ask about the traditional medications, because some of them don't necessarily have the best evidence either. So I'm not singling out complementary therapies for this, just I don't want to upset anybody. Watch out for the placebo effect, because again, uncontrolled studies where people just take this medication and they say they felt better, that's very likely to happen even with sugar pills. So, that doesn't necessarily tell you anything. And of course, lots of new therapies are hyped. Cannabis is the best example of how it went from totally illegal to the next best thing, pushing forward. And in fact, we went into a realm where everybody's taking cannabis now for their symptoms, and we really don't have any evidence to know how to use it. And that's a problem. Always ask though about there are any potential risks or interactions with the other treatments you're on, and never assume, like a lot of people think that natural things make them safe. Cyanide is natural, right? So being natural doesn't make it safe. Always ask about the costs and the burdens to you, right? So if something's very costly, I'd think harder about it than not. And remember that if something hasn't been proven or tested, it's just as likely to hurt you as it is to help you. So be really just mindful of that whenever you're looking at these types of therapies. Okay, we're in the home stretch now. We're talking about what is palliative care. Palliative care is an approach to care, which improves the quality of life of patients and families facing the problem associated with a life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And that's the WHO definition that I think many palliative care physicians can quote you at the drop of a hat. Key points just to remember: palliative care can be potentially provided by any physician, right? You don't always have to see specialists, although in many cancer settings, that's becoming increasingly more common that specialists are getting involved earlier. Palliative care is not a place. Palliative care is not the same thing as end-of-life care. We provide palliative care much earlier in treatment now than we ever used to, early in the course of illness, even alongside therapies that are intended to prolong life. But palliative care itself is not intended to prolong life or shorten life, right? So, for example, MAID is not considered the same thing as palliative care. Medical assistance in dying, I should say. That may be something else that to pursue for other reasons. But when we're talking about palliative care, that's a sort of complementary thing that works alongside other potentially curative therapies. Okay, when should you see palliative care? I love this poem from Piet Hein called Timing Toast. There's an art to knowing when, never try to guess. Toast until it smokes and then 20 seconds less. As a palliative care provider, whenever I see somebody referred to me, my invariable conclusion is that it probably should have been referred a week ago or 2 weeks ago. The problem is, of course, it's very hard to know until symptoms get out of control or problems get out of control that I should have called palliative care sooner, which is why people are getting more into the habit of early routine referrals, even before potentially people have symptoms, because this problem of just waiting too long until the toast catches on fire has been out there. So again, there's no ideal timing. Earlier is becoming the vogue, and you don't be surprised if your cancer specialist has been referring you to palliative care, even alongside your ongoing therapies. And we're sort of becoming more and more enamored of what we call this bow tie model. And this is from my colleague and friend Pippa Hawley out in BC. It's a wonderful little model looking at how the two, disease management and palliative care, relate. So you see the blue triangle starting at the left. And if you start off in the sort of middle of that blue triangle, you get both disease management, but also palliative care at the same time. And as you move along, if you're going along in the center of this bow tie from left to right, you're moving through, and pain and symptom management are just as relevant to you while you're getting disease management as they are after you might get disease management. And depending on how you respond to your disease management, if you recover, you go into rehabilitation, which is upwards, and then finally survivorship on the right. So palliative care ends and you're in the survivorship world, which is great, and that's what we want. At the same time, if things don't go the way we want and disease seems to be progressing, we move maybe more from the co-management of pain and symptom management to where palliative care might take over more. And from disease management, you may end up in a palliative care unit or hospice, but certainly followed and perhaps having palliative care providers take over. And then, of course, we move into the afterwards, which is bereavement and support for your family. And that's kind of how we envisage things. And obviously, we're here regardless of which way you go, and we're cheering just as hard as everybody else for you to get better. We're also trying to be realistic and say that, look, we, as much as we want plan A to work out, we're here to make sure there is a plan B, because only a fool would not prepare a plan B. Future directions, timely palliative care and better access to timely palliative care is a big thing. We're trying to go for more effective symptomatic treatments and develop them. We've got a palliative care research collaborative now across the country that's working hard on a number of new therapies to try to nail down some more effective things, the cannabis trial being one of them. Moving potentially to personalized palliative care. So many of you are getting potentially genetic assessments to look for mutations that might suggest that your tumor is more susceptible to this treatment or that treatment. We also may be able to identify people who may be more or less responsive to certain types of pain medication. So getting personalized palliative care alongside your personalized cancer care, well, that would be a really good thing, because it just means we get faster to our goal, which is making you feel more comfortable. And with that, I'm going to stop. I hope this was not too high level, too low, or too fast, but I am very keen to take and answer any questions you might have. Thank you.
Thanks, Dr. Downar. That was, I thought, incredibly engaging and very interesting, and a lot of information, but with lots of humor thrown in. So that always helps as well.
Thank you.
So we'll start with, we'd encourage anyone who has questions to use the Q&A chat box to ask those questions. We'll start with the first one, which is, would palliative care be able to address pain from BIONJ, which I have to admit I've never heard of before. I had to look it up. So it's bisphosphonate-induced osteochondrosis of the jaw. And are you familiar with that? And what some of the management options? Yeah,
so bisphosphonates, which are commonly used for different reasons. One of them is to treat or prevent osteoporosis in some cases, and used to be used actually as part of pain management and palliative care. And it results, unfortunately, in a complication of jaw, that osteonecrosis, which is quite uncomfortable. I'm happy to report that it is quite rare, which is, of course, no comfort to the people who get it. Nobody likes to be special in medicine, and with good reason. The challenge, I think, if you're having symptoms from osteonecrosis of the jaw or any other reason, and your usual physicians are not able to get that under control, I think requesting assessment by a palliative care physician would be very reasonable. I think if you're somebody for whom maybe a more survivorship picture is your pathway, like you're actually improving, and they weren't thinking to involve palliative care, perhaps even a chronic pain specialist might be helpful here, and they should have access to some resources there. But yes, if they don't have access to those resources, asking them to sort of run your case by a palliative care provider, if the palliative care person is willing to see you and help you, they may be able to look at different options there. It's a challenging situation to get rid of the pain entirely. Managing the pain, that may be possible, yes.
Great, thank you for that answer. And the next question is around cannabinoids. So are cannabinoids used more with oncology patients than other disease groups in your experience? And have you found that doctors are becoming more comfortable in prescribing them? That's been one of the challenges as well for patients, is that sometimes your traditional healthcare provider and physicians are not always comfortable with what the prescription should be.
Yeah, I mean, it's a little bit like, you know, so I have 4 kids. My daughter's 14 and she's, you know, on Instagram and Twitter and all these things. And I don't think I'm that old, but I look at these social media platforms and I'm like, I have to learn how to use them to like make sure that my daughter's okay. And of course, my daughter can run laps around me on these things. Like she knows these things way better than I do. And the notion of me supervising her and making sure that she's using them appropriately is almost laughable because it's ridiculous, right? It's like asking my toddler to make sure I'm driving properly. With these newer advents of therapies, particularly something that is very much in the public sphere and has always been kind of scorned or pushed to the side with cannabinoids, you're never going to, I think you're going to find a low level of familiarity and comfort among most physicians in general, even palliative care physicians. I would say palliative care physicians are probably the more comfortable with prescribing these than most people would be. But then the other problem is that how much you prescribe and how you even get it. In the old days, it was, you know, and still now when you're filling out, it's not even a prescription, it's a dispensing form, right? It's a sort of a letter that you indicate what percentage of THC you want the person to get, which isn't necessarily even what you want. You're probably more interested in the CBD. So the regulations around it often and the forms didn't even make sense to what you were trying to do. Now we're in a much better situation with the dispensaries if people are able to just go and afford it and buy it themselves, because then I can just tell you, get the, you know, the 95% cannabis, the CBD, and take X number of I'm not going to use a number here because I don't want anyone starting this, please. But I just start at this number of milligrams a day and then go up as tolerated. And I would say that, you know, people with cancer, my guess would be that people with cancer are probably taking this more than many other people. But the other problem is, of course, the recreational market has exploded to the point that we actually ran out of cannabinoids for our patients in the early days of legalization. We smoked our way through all the pot, like Canada smoked its way through its entire pot stockpile so fast that we ran out. And so again, and now we're at the point where if I'm trying to do a properly constructed study, our challenge is finding people who aren't just going to take the stuff on the side anyway. So we can't really get a placebo group. Somebody's just going to go and, you know, get it from the dispensary. So we're really in trouble. We're not in trouble. We're struggling on that front, but we're hoping to have more information on that. I would say if, you know, you should be able to find a physician now who can prescribe this stuff. Many family physicians are comfortable with this now. Palliative care physicians definitely should be comfortable with this. And I would strongly encourage you to ask about it when you go and see people. I would say if you're struggling to get any of your symptoms under control, pain, nausea, or sleep, definitely ask about cannabinoids because they may be a good helpful start for you.
Great. And it sounds like there is more knowledge then. So they should be a little bit more accessible. The next question we have is heaviness in hands and legs due to chemotherapy. Is it permanent or can it go away with medication? And if yes, what could be used to help manage that or help it go away completely?
So this sort of stocking and glove type neuropathic pain, I believe, is what you're describing there, and it's a very common side effect that people get with certain types of chemotherapies. And some are the powerful chemotherapies that you might get during your initial treatments, like the taxanes. And it might also go on with things like capecitabine or Xeloda or these other chemotherapies, the folate inhibitors. The idea is, yes, I mean, when you damage neurons, the actual nerve cells, neurons are remarkable cells. So the cell body itself, like the actual body of the cell, is way back in your spinal cord or next to your spinal cord. And the actual nerve that comes out to the tissues is just a little extension of that neuron. And so if that gets damaged, the little axon, that little axon bit that's growing out to the tissue can grow back, but it grows back very slowly, 1 millimeter a day. Every month it grows about an inch, and about a foot in a year. So, if you get a significant injury and it has to regrow itself or repair itself, that can take a long time. And it may, but often people, after they stop the chemotherapies or the other therapies, they will report that the symptoms get a little bit better. So don't lose hope. It's very likely that it will get better. There are a lot of things that can be done with it, the neuropathic agents that I mentioned. So particularly the antidepressants or the gabapentin or pregabalin are the common ones that people would use for that.
Okay, great. And we have time for, I think, one more question. And it's specifically around stage 4 breast cancer, but that has been metastasized to the liver. And what can be done to manage pain that's coming from the back or back muscles, spine, where mobility is limited? Or is that something that really you'd have to see someone to assess that?
Yeah, it's a great question. It's funny, I literally just got an email from a colleague. So we often work with our radiation oncologists to look at potential for radiation to help. So sometimes radiation doesn't necessarily cure a tumor, but they can make masses shrink. And that's sometimes pretty good for us in helping us manage symptoms. And they actually have a number of protocols underway now looking at trying to improve people with liver stretch. And sort of liver enlargement as a result of masses, because the liver doesn't have neurons in it, but the capsule, the lining of the liver, when it gets stretched, that's what hurts, and that can hurt. If you're talking about pain in the back, it's hard. Again, I would need to know if it's that pain related to the swelling in the liver versus something else that might be going on in the bones or within the muscles themselves, which happens. It's unusual, but it happens. And all of those would have potentially different effective therapies. So yeah, I'm sorry. I'd love it if I could give you more specific advice, but probably not appropriate for me to do so.
Well, I think you just really reiterated the need for the role of palliative care physicians within this pain management space and how patients can access palliative care throughout their cancer treatment. That would be incredibly helpful. So hopefully the person who asked the question is able to access a palliative care team. And I think that we're out of time in terms of our time with you, Dr. Downar, but thank you for that engaging, very interesting presentation. Kathy, I will turn over to you.
I just want to thank you, Dr. Downar. That was fantastic. I really enjoyed that presentation. Thank you. I'm sure we can expand on that. Thank you so much.
You can see my email, and if you can see my email. If you have any questions, don't hesitate. I'm happy to take them.
Thank you. Thank you.
Bye, guys. Take care.
Bye-bye.
Thanks, Dr. Downar.
That was great. So our last presentation for this session will be from Jenn Gordon, who has been facilitating our Q&A throughout this webinar. Jenn is the Director of Operations at the Canadian Breast Cancer Network and has been with our organization for over 10 years, primarily working on our patient education programs and supporting our advocacy initiatives. She will be reviewing some of the digital resources that exist to support decision-making and advocacy. Jenn, I'm going to turn it over to you.
Back to me. Thanks, Kathy. So instead of actually a formal presentation, I wanted to actually just take a little bit of time to review and speak specifically to digital resources that help support decision-making and advocacy. I'm just going to wait till this screen share pops up. There's a bit of a delay. And so for the Canadian Breast Cancer Network in particular, we really focus on patient education and advocacy and how those two work together A priority for us has always been ensuring that patients have the information that they need to make informed decisions about their treatments, and also advocating for access to optimal care. So really looking at a couple of different navigation tools that can help support this. And when we're looking at a lot of the work we've done, particularly in the metastatic breast cancer space, has really been around addressing timely and equitable access to new therapies. And so one of the areas that we've focused on is around that drug access piece. And so we've developed two navigation tools. Some of you may be familiar with these, some of you maybe not. So I just wanted to do a really quick overview of both of these tools. And they can be found on our website, which is available in both French and English. And they're updated on a regular basis. So they're very easy to navigate, updated in real time, and have current information. So MedSurge is actually the first tool that we're going to look at today. I should say that all of our website, all of our informational resources, all of our navigation tools are all actually done with an advisory board of patients, as well as healthcare professionals. So this actual MedSurge database was developed with metastatic breast cancer patients, informing what the information that they thought was really important for other patients to have and how it may be made accessible. And so there are a few limitations within this database. And I will say that it's really designed as an informational tool to help guide decision-making discussions with your oncologist or with your healthcare professionals. It's not designed as to prescribe treatments. And so it's not designed to replace those conversations, but rather to help support those. And secondly, one of the components that wasn't added to the MedSurge database was actually the line sequencing. And we get quite a few questions about this in terms of how come I can't tell what it's approved for and which line setting. And the reason for that is that, one, a lot of the line settings for metastatic breast cancer drugs change as new therapies are added and become available. And the other piece is that sometimes, whether it's through exceptional access programs, private insurance, various programs that oncologists may be aware of either in their center or within their province, sometimes you're able to access it off-label. So while a drug may be only approved on a provincial formulary for first-line metastatic breast cancer, in a certain setting, you may actually be able to access in a second or third or fourth line, depending on what other programs exist. So we didn't want this to restrict what patients thought they may have access to. So just to quickly walk through this, you're able to search by the name of the drug, either brand name or generic name, specifically by the breast cancer type. You can also select multiple types in this resource. And then we recently added early stage breast cancer therapies to this tool. But for the first couple of years of it, it was just metastatic breast cancer therapies. And that's where we usually see new treatments introduced within the metastatic breast cancer space, and also selecting a region. So you can either search by the province, territory that you live in, or if you're really trying to get an understanding of what might be accessible across Canada that isn't necessarily covered in your province, you can leave this blank and actually see all of the options across Canada. And then the last piece that is relevant in terms of access is, where is this drug in the approval process? So this MedSurge tool includes all drugs that are Health Canada approved. If they are still in clinical trials but are not Health Canada approved, they won't appear here. And there is a clinical trial section I'll speak to after. But these are all Health Canada approved drugs. And then what we do is track them as they move through the approvals process. And this has an impact on whether or not there's support programs available, whether or not private insurance may cover it. So for example, while you might not be able to access a therapy that's covered provincially on a provincial formulary, if you have private insurance, once a drug's Health Canada approved, your private insurance may cover it. So understanding where it is within the drug approvals process, and that's something we track quite closely, and then also once it's listed on the provincial formularies. So if you filter by whatever criteria you're looking for, and I'm not going to select any, we'll just get the entire database up. But you have this really high level overview, again, highlighting the generic name, brand name, breast cancer type that it's specifically for, and the stage and where it is in the approvals process. And so you're able to, at a very quick glance, see what options might be available to you. And then if we're looking at, and I'm just going to click on one of the more generic drugs in terms of looking at an actual drug profile. And so that's where you'll receive a little bit more detailed information around that specific drug. So along with all the information that's already been provided, also this includes the type of therapy, the manufacturer, which for the newer treatments might be incredibly important in terms of what type of supports they're able to offer. So again, if a drug is not covered yet on the public provincial formulary, but is Health Canada approved, there may be some supports or a portion of the cost that the manufacturer might be able to cover. And this would be incredibly important to be aware of. Drug format we've included because in some provinces, oral therapies are not always covered. And then also you get a quick overview of what provinces and territories do and don't fund this therapy. I will draw your attention to the bottom of this tool actually has quite a robust FAQ section. And the reason for that is to help support advocating and patient advocacy for access to treatments that may not be accessible to them. And so in here you can find the actual a downloadable list of the provincial and territorial formularies and their contact information if you're looking for exceptional access programs that might be accessible to you. We also list various patient manufacturer assistance programs through our financial navigator and how you can connect with them. What to do, there's a section around what to do if drugs aren't covered on the formulary. And then also some navigation points around private insurance and also linking you to clinical trials. So there are actually a couple really great clinical trials navigators now that have been developed online to help cancer patients, and breast cancer is included in this, find clinical trials that are suitable for them. And that might be a really great option as well. So connecting patients to that. And then the last, or the second rather, navigational tool that I wanted to quickly touch on was the financial navigator, which really lends its support to MedSearch. And again, trying to address, we know what we know is a critical need for patients and families is that financial impact of a cancer diagnosis. So this navigator also has additional information around legal implications, health insurance benefits, understanding what's covered by Medicare. Pre-COVID, trying to find travel insurance. Now we're all sort of grounded for a little bit, but hopefully at some point we'll get to travel again. So looking into some of those really practical issues. And then one of the challenges that we've faced when trying to navigate patients, and also that we heard from patients, is that unless you were connected with the social worker at the cancer center, or unless you happened to Google the right resource, it was really hard to understand what financial resources might be available to you. And so this database actually compiles all the financial assistance programs from provincial and federal governments, from community organizations, everything from drug coverage to income supplement programs to really just practical expenses like covering parking and travel to and from the cancer centers. Again, you're able to search by the region you're looking for. And then also, if you fall under a specific demographic, searching by one or multiple demographics. And similar to our MedSearch tool, we wanted these tools to really reflect each other and be easy to navigate. Instead of having a drug profile, what you end up with is a list of these resources. So you'll be able to, again, have a really high level of what you might qualify for. And instead of having to go to every single website and read through the eligibility criteria, which can be onerous to say the least, this resource profile will actually really quickly highlight what the benefit is, what the demographics are, and that eligibility criteria piece, so that you know whether you're wasting your time to go and look at it or whether it's something you might want to explore further, and then also how to apply for it and the links to go there. So given that we have one more minute in our session for today, I think I'll close with that. I do welcome questions. We wanted to leave the question and answer period to our two physicians that joined us, but I would welcome questions and would be happy to accept those. I will put my email address up on the screen in a minute. You can just email me directly. Kathy, I will turn it back to you.
Thank you, Jen. That was great, highlighting those resources. I'm sure you'll get some questions, but it was quite clear. Thank you very much. So before concluding this education session, I would like to thank once again our presenters and everyone who's joined the webinar. I know for myself, I've learned quite a bit today, and I found this to be very valuable, and I hope you share my feelings around this session. This was great. So I once again want to thank our sponsors, Novartis, Pfizer, Oncology, AstraZeneca, Eli Lilly, Knight Therapeutics, Merck, and Roche. Thank you very much.